Obesity. The priority concept for this chapter is nutrition, with the interrelated concept for this chapter being fluid and electrolyte balance. There are several different nutrition standards for health promotion and maintenance. We have the Dietary Reference Index or Intakes, Dietary Guidelines for Americans, Canada Food Guide, Eating Well with Canada's Food Guide, USDA My Plate, vegetarian diets, and cultural awareness. This is a picture of My Plate, which is very commonly used in the United States, basically showing you the portions that are recommended for a healthy diet intake. A third of the world's population is considered to be overweight or obese, and this is the leading cause of preventable death. Overweight versus obesity versus morbid obesity. Being overweight is considered a BMI of 25 to 39. Obesity is reflected by a BMI of 30 or higher, which is further divided into three categories. We have class 1, which is a BMI of 30 to 35, class 2, which is that 35 to 40 or 39, and class 3, which is a BMI of 40 or higher, also known as severe or extreme obesity. So there's several different things that can lead to obesity. One of those is called adipokines, which affect the appetite and fat metabolism. Dysfunction will result in an increased appetite, overstimulation of the autonomic nervous system, blood vessel inflammation, and ventricular hypertrophy. The fat distribution is a better predictor of increased health risks than of obesity. Complications of fat distribution include cardiovascular, endocrine, gastrointestinal, genitourinary, integumentary, neurologic, psychiatric, respiratory, and musculoskeletal concerns. Causes are environmental, genetic, and behavioral. A common cause is eating that high fat and high cholesterol diet. Physical inactivity, drug therapy, such as with corticosteroids, estrogens, NSAIDs, antihypertensives, antidepressants, antiepileptics, and certain oral antidiabetics can also cause an increase in weight. So when we are interviewing someone who may have an issue with obesity, we have to use the acronym RESPECT. We need to create a rapport with the client in an environment that is safe, ensuring safety and privacy, encouraging the client to set realistic goals, providing compassion, and using tact in conversations. As with any other medical issue, we cannot be judgmental. We also need to determine the following to assist with the development of plan. What is the client's economic status? What is their usual food intake and their appetite? What are their eating behaviors and attitudes towards food? Do they eat because they're hungry? Do they eat because it's a comfort? It helps with depression, they're bored, etc. What is their culture? What chronic diseases do they suffer from? What medications do they take, including herbs and over-the-counter medications? What is their activity, their family history, their developmental level, and what forms of weight loss have been tried in the past? We also need to do that physical assessment, which includes the height and weight and determining the BMI, getting a waist, arm, and calf circumference, getting the waist to hip ratio, and checking their skin for yeast and other infections, especially in those skin folds. Those are prime areas to grow yeast. We're also going to do a psychosocial assessment. What are their personal circumstances, their emotional factors, their perception of weight, weight reduction, the benefits of losing weight or those health benefits, lifestyle changes. Ask questions about their health beliefs regarding their weight. Determine if depression is present. And then we need to begin analysis. Is their weight gain due to excessive intake of calories? We know that excess weight can stress all the vital organs. So how are things working? So what do we do? Health promotion with weight management and exercise are important. Even a 5% weight loss can decrease the risk of uh, coronary artery disease and diabetes mellitus. It's important to provide care to the client in an appropriate environment that's designed for the safe care of the bariatric client. Non-surgical management, which does include behavioral management, involves nutrition modification with or without drug therapy in combination with an exercise program. Weight loss can eliminate diabetes mellitus, hypertension, depression, and sleep apnea. So how do we improve nutrition? Well, there's several different diet therapies out there. There is that short-term fasting program and a very low calorie diet, 200 to 800 calories a day. This does require a cardiac evaluation and medical supervision, and there is a very high risk of regaining that weight back. A nutritionally balanced diet where the client is taking in 1,200 to 1,800 calories a day. This has a very conventional distribution of those diet components, the fats, the proteins, the veggies, etc. They may require vitamin and mineral supplementation. Going on an unbalanced, low energy diet, which would be a low carbohydrate or diet restricted diet. It's important to encourage protein in vegetables, but we restrict certain carbohydrates and high fats. There are mixed results, but this type of dieting is very popular. We can also consider nutrition therapy. This is where there's close interaction between the client, caregiver, provider, nurse, and dietitian. This meets the client's needs, their habits, their lifestyles, and is very realistic. The diet is evidence-based, nutritionally balanced. There's a low risk-benefit ratio. It's practical and it's conducive to long-term success. The calorie needs will be based on the client's current weight, their gender, and their activity level, and it's designed to lose about 2 pounds a week. 5 to 10% loss of body weight has been shown to improve the glycemic control and reduce cholesterol and blood pressure. An exercise program. By adding physical activity to a healthy diet, it can produce more weight loss than dieting alone. For example, walking 20 minutes a day and increasing the time as endurance increases. It can be done all at once, or we can break up that 20 minutes throughout the day. Then there's drug therapy. There's 6 medications that are currently approved for overweight and obesity treatment. And you know how the medical world is. Things are constantly changing. So even since this was prepared, there can be other medications that have been added. So there's the liraglutide, which activates appetite regulation in the brain. Important not to take this one if you are taking insulin. There's the naltrexone bupropion, which combines an opioid antagonist, naltrexone, with the antidepressant bupropion. Should not take this one with uncontrolled hypertension, seizures, eating disorders, or drug and alcohol withdrawal. There's orlistat, which inhibits lipase. It is encouraged that you take a multivitamin daily with this. And it's also important to decrease fat intake at least 30% of the food intake. Because if you don't, then that high fat intake will cause loose stools, abdominal cramps, and nausea. Then we have the phentermine topiramate, which is a short-term weight loss drug that's combined with an anti-seizure medication. Very important to not take this if the client has glaucoma or hyperthyroidism. And this can cause birth defects. There's the semaglutide, which increases the resting metabolism and feeling of fullness. It helps reduce appetite, but it can increase the risk of pancreatitis. Then we have the setmelanitoids, which target impaired MC4R pathway or the underlying hunger. This one can affect sexual function. It can cause mood changes, depression, or suicidal thoughts. It can also cause skin changes, including darkening of moles. Other treatments for obesity include cryolipolysis, which is basically fat freezing, and this will help reduce fat in certain body areas. However, for whatever reason, this is not suggested for clients who are overweight or obese. We have behavioral management, which changes the daily eating habits to lose weight through self-monitoring, stimulus control, reinforcement techniques, cognitive restructuring, counseling, or that 12-step program. There is an oral superabsorbent hydrogel, which is an oral capsule that's defined as a medical device instead of a drug, because when it's swallowed, it releases a superabsorbent hydrogel particle that absorbs water and food to take up about 25% of the gastric volume. The water is released in the intestines, and this contributes to the feeling of fullness. Clients can lose up to about 5% of their body weight this way, but it can cause some bloating, abdominal cramping, and flatulence. We also have complementary and integrative health, which can help suppress appetite and decrease food intake. This would include acupuncture, acupressure, Ayurveda, and hypnosis. Surgical management. Those clients that are eligible for surgical management include those that have a repeated failure of non-surgical interventions, a BMI equal to or greater than 40, a weight that is more than 100% over their ideal body weight, clients that don't respond to traditional interventions, or clients that have a BMI of 35 or greater with other health risk factors. Bariatrics is a branch of medicine that manages clients with obesity and its related diseases. There are multiple surgical procedures available, and these are dependent on the surgeon and the client. Preoperatively, most care would be similar to any client undergoing any abdominal surgery. There is an increased surgical risk for pulmonary thromboembolic complications and death just because of that increased weight. It may require a certain amount of weight loss prior to surgery. It may require a psychological assessment and testing for depression, substance abuse, and other mental or behavioral problems. The nurse role is to reinforce health teaching in preparation for surgery. There are several different operative procedures, such as liposuction, which can remove adipose tissue in certain areas of the body. Gastric restriction, which is the easiest one to perform. It does allow for normal digestion without nutritional deficiencies. And this is what you're seeing in the left-hand picture. Banding procedure, which places a band around a portion of the stomach to decrease the amount that it will hold. There's the vertical sleeve gastroplasty, which removes about 3/4 of the stomach. There's a biliopancreatic diversion with a duodenal switch that removes about 80% of the stomach and then bypasses the upper portion of the small intestine. There's a single anastomosis duodeno-ileal bypass with sleeve gastrectomy. There's gastrointestinal electrical stimulation. Gastric bypass, which is the most common bariatric surgery. However, it is more invasive and does have the highest risk for post-op complications. It also results in malabsorption. This is also known as the Roux-en-Y procedure. It is, once again, more invasive and does have more frequent postoperative complications. Surgeries might be open or they can be minimally invasive. Postoperative, the client may no longer have complications of obesity, such as diabetes mellitus, hypertension, depression, or sleep apnea. Post-op care will be dependent on the type of surgery, but the major focus will be on the client and staff safety. Trying to move around clients who are overweight does impose a very significant risk to staff and the client. The client should be placed in a bariatric room. We should always use additional personnel to move or reposition the client. We should assure that the client is not touching side rails or lying on tubing or having tubing within skin folds. This can create pressure injuries. And we should always make sure that the skin is clean and dry. The priority in these clients, as with almost everyone, will be airway management. These clients need to be in a semi-Fowler's position. Very important to monitor their oxygen saturation and provide oxygen therapy as necessary, such as BiPAP or CPAP. There is also a risk for anastomotic leaks. What is anastomotic leak? Well, when we cut something apart and then we sew things back together, that's the anastomosis site. And, it's just sutured. You can't guarantee that there's not going to be any leakage or that one of those sutures might break loose and potentially cause leakage, especially if we're allowing the client to eat prior to that site healing. So an anastomotic leak could be very serious and it could lead to potential peritonitis. It is important for us to use SCDs on these clients and administer anticoagulant therapy to help prevent those thrombi. An abdominal binder is important to help prevent wound dehiscence and measure abdominal girth daily to make sure that we don't have distension. For 24 hours, we'll have an indwelling urinary catheter. Physical therapy should consult for transfers and ambulation, and these clients should be ambulated as soon as possible. We also need to make sure that we're repositioning and turning the client every 2 hours and using absorbent pads between the skin folds, making sure that we're doing appropriate skin care. Provide appropriate pain management and observe for signs of that dumping syndrome. Food that's introduced when appropriate begins with clear liquids and then full liquids. This may only be 1-ounce servings. After 1 week, then pureed foods will be introduced instead of just clear liquids, and it will only be about 5 tablespoons of food. After several weeks, then we can begin introducing soft foods. By post-op week 8, the client should be able to take in solid, nutrient-dense foods. The client should be instructed to eat and drink slowly and consume only small meals. They should stop eating before they're full. They should also choose foods that are high in protein, avoiding high fat and high sugar content foods. And again, observe for that dumping syndrome. This is where the food enters the small intestine too rapidly. The client will experience tachycardia, nausea, diarrhea, abdominal cramping. We deal with it by having the client lie down after eating. This kind of reduces the effects of gravity. It helps slow down the passage of food through the gastrointestinal system. And we may also have to do some dietary adjustments, administer antidiarrheals, administer acarbose, and it unfortunately may require surgical intervention. So with care coordination and transition management, treatment of obesity needs to focus on the long-term reduction of the health risks and those problems associated with obesity, and that improvement in the quality of life and the promotion of health-oriented lifestyle. Discharge teaching includes nutrition, that diet progression, as I've already mentioned, in addition to vitamins and supplements, and making sure the client stays well hydrated. The drug therapy, which might include analgesics and antiemetics as necessary. Wound care, make sure they cover that wound when they shower or whatever the provider prescribes. We need to educate on their activity level, avoid lifting, and slowly progress their activity. What symptoms should they report? They also need to be encouraged to keep all of their follow-up appointments. And they also need to continue with nutrition and exercise classes. In about 18 to 24 months, considerations of skin removal may be done, especially that abdominal apron, which is called a paniculectomy. We also need to consider support groups with clients such or those that have like illnesses or situations. And we need to talk about self-care. We need to individualize that exercise program non-surgically. Have them keep a food journal that includes their mood and their events around eating. And educate them that post-operative bowel movements are likely to change. So, case study. We have an 88-year-old male that's been admitted for dehydration. Upon assessment, we have dry mucous membranes, generalized weakness, difficulty ambulating, very little appetite are noted by the nurse. His weight is down from 112 to 98 pounds over the past 3 months, and dentures are loose and poor fitting. Which assessment findings support malnutrition? And which assessment findings support a failure to thrive? Well, malnutrition. We've got decreased appetite, weight loss, the dry mouth, generalized weakness, poor fitting dentures, and difficulty ambulating. With the failure to thrive, the weakness, unintentional weight loss. Other symptoms might include that slow walking speed, low physical activity, and exhaustion. The client is admitted to the hospital and the nurse reviews the client's admission lab results, which result supports a diagnosis of malnutrition. Hematocrit of 37%, hemoglobin of 12 grams per deciliter, prealbumin of 13 milligrams per deciliter, or serum albumin of 3.5 grams per deciliter. The correct answer is C. The serum albumin, hematocrit, and hemoglobin are all low normal values, and it can indicate malnutrition, but that serum albumin value of 3.5 is low, and it does reflect a nutritional status that's a few weeks before testing, so it's the most sensitive protein study. A 13 milligram per deciliter prealbumin level is low, um, and it's a more sensitive indicator of protein deficiency because of its short half-life of 2 days. On assessment, the client is noted to have conjunctival xerosis, dry skin, follicular hyperkeratosis, and a bright magenta or purple tongue. Which vitamin deficiency does the nurse suspect? Vitamin A, C, D, or K? The correct answer is vitamin A. Which dietary item should be removed from the client's nutritional tray? Applesauce, granola, scrambled eggs, toast with butter. The correct answer is B. Based on his symptoms, this client needs to be on a soft diet. His ill-fitting dentures would also make it really difficult to eat that granola. And granola is not a part of a soft diet plan. All other items reflect soft items that the client could have. The client is ordered daily multiple vitamins with zinc and iron supplements. Which nursing interventions promote oral nutrition intake? Select all that apply. Delegating a UAP to feed the client. Providing mouth care before each meal. Placing a small bore nasoduodenal tube. Assisting the client to sit up in a chair. Ordering foods that the client likes to eat. The correct answers are all but C. Placing a feeding tube with continuous feedings is going to cause the client to have a decreased appetite. Having that UAP feed the client can increase oral nutrition intake, especially since the client is weak and might be too tired to feed himself. What possible complications does the nurse observe for when administering total parenteral nutrition? Infection, dehydration, hyperglycemia, electrolyte imbalance. The correct answer is C. It does significantly increase the blood sugar. Clients receiving TPN may temporarily even be placed on insulin even though they are not diabetic. An older adult with anemia requests help with menu choices. What type of food would the nurse encourage the client to eat? Prunes, oranges, skim milk, wheat bread. The correct answer is skim milk. With that vitamin B12 deficiency in a client's diet, it can result in anemia. Older people are at risk for several nutritional concerns, including anemia from vitamin B12 and iron deficiencies. Vitamin B12 can be found in meats, fish, dairy, and egg products. Prunes and oranges can assist with adding fiber and vitamins to the diet. And encouraging complex carbs such as wheat bread is also important for good nutrition. The nurse is caring for a client who's preparing for bariatric surgery. What is the appropriate nursing response when the client states, "I'm afraid this surgery won't work"? Is it, "Are you afraid you will stay overweight for life"? "This surgery always works. It'll be fine." "Tell me what concerns you most." Or, "We will postpone the surgery until you decide how you feel." The correct answer is C. We need to allow that client to explore his or her feelings by asking what concerns the client the most.